Hi everybody. Welcome to the first week of the Epidemiology of Substance Use Disorders. What we're going to do this week is provide a quick overview of the kinds of concepts and research and intellectual traditions and the terminology that's developed around this complex field called substance use epidemiology. And we're going to start with a description of what epidemiology is itself as it's applied to substance use disorders. In general, epidemiology is the study of the distribution and the determinants of disease entities. In the case of substance use disorders, we're talking about psychiatric conditions. And one condition is alcohol and drug dependence or addiction. So what we're interested in epidemiology is finding out how they're distributed across different population groups, males and females, African Americans and Hispanic Americans, Europeans and Russians. So it's how these disorders are spread out within a population, how they occur in terms of their frequency. Are they more or less prevalent in some groups than in others? What the risk factors are and their relationships to psychiatric disorders. Epidemiology tries to accurately estimate incidence and prevalence and understand the causes of a particular disorder, whether it is heroin addiction or whether it's a preference for ecstasy or some sort of club drug. And epidemiology data is useful for the purposes of finding out how to prevent the occurrence or reduce the incidence of a substance use disorder. But it's also useful in designing early intervention and treatment programs. There are a number of different traditions that alcohol and drug epidemiology borrows from. The first one is social epidemiology, and that's usually characterized by survey studies of large population groups to find out who's using different types of substances and what patterns of use there are in terms of using a substance to intoxication or for recreational purposes and what problems are experienced. There's another tradition that focuses on the more extreme cases, which is called psychiatric epidemiology. And we borrowed a lot of methods from there in terms of how to apply diagnostic criteria to count people with substance use disorders. Clinical epidemiology looks at the conditions, usually disease conditions, that people develop and that are observed when people come into a hospital setting, such as liver cirrhosis in alcoholics. We also borrow from pharmacoepidemiology, studying how drugs can influence or prevent a relapse, and genetic epidemiology, which is studying how different familial and genetic factors contribute to the risk of a substance use disorder. So we're talking about a full spectrum of psychoactive substance use, starting from beneficial use in terms of some substances that are used for medicine, pain relief, for example, can be used without very many problems, but then some people begin to use in a casual and a recreational way, and they put themselves at greater risk. And then some people develop problems and other people develop chronic dependence. That whole spectrum is the subject of epidemiology of substance use disorders. So what is a substance use disorder? Well, there are diagnostic criteria now that have been developed in the two systems that we'll be speaking about in this course. The first one is the Diagnostic and Statistical Manual of the American Psychiatric Association, and it's now in its 5th revision. The second one is the International Classification of Diseases that's used all over the world, and it's formulated by the World Health Organization, and the last edition that is now being used in most healthcare systems is ICD-10. So these two systems have different ways of estimating substance use disorders when it's present or absent. And it depends on the number of symptoms that people report, or the number of symptoms that are observed in a clinical interview by a trained clinician. So for ICD, we're talking about what triggers the diagnosis of a mental disorder, and in particular a substance use disorder. Usually, a substance use disorder represents something that is clinically recognizable and significant. And it's a set of symptoms or behaviors that are associated in most cases with distress. Somebody is not feeling well, they're not functioning well, and the distress that they experience and the symptoms they experience interferes with their personal lives. This differentiates a disorder, a mental disorder, like a substance use disorder, from social deviance, or people who don't have a personal dysfunction, who are just using for recreational purposes. So it goes over that line from people using for cultural purposes like alcohol, or using a drug where they're getting high once in a while, to a disorder where they lose control over their behavior and they find it very difficult to function. Here are the diagnostic criteria for a cannabis dependence syndrome according to ICD-10. And these criteria are pretty much the same across the different substances that you should become familiar with. The 10 or so substance classes all use the same criteria in ICD-10. And it ranges from a strong desire and a sense of compulsion to use the substance to the persistence of substance use, even in the face of harmful consequences. Here are the DSM-5 criteria for substance use disorder. And you should compare the two. Compare ICD-10, which has 6 criteria, to the 11 criteria in DSM-5. There's a lot of overlap. They both include tolerance and withdrawal. They're combined in different ways, and they're both organized across a continuum of severity. There are other important terms that you need to become familiar with in this course on epidemiology. And we'll, for the most part, be using the terms formulated by the World Health Organization. Harmful use is a pattern of psychoactive substance use that is already causing damage to health, whether it's physical health or mental health. At-risk or hazardous use is a pattern of use where there is no harm, but people are at much more elevated risk of developing a problem or dependence. So many people who drink and drive are not dependent on alcohol, but they are engaging in hazardous alcohol use, because when you combine drinking and driving, the risk of an accident is substantially increased. So within ICD, there are terms that look at this complete continuum of severity. There are a number of limits to psychiatric diagnosis, which make it different from diagnosis of cancer or heart disease and medical conditions. But over the years, psychiatric epidemiology has dramatically improved the definition of mental and addictive disorders. but they still lack the kind of conceptual purity that we would like to have when we say that someone is addicted or not addicted. Part of the reason is because there's a lack of a gold standard, a laboratory test, and there's a continuum of severity. So it's difficult to recognize a disorder at the lower levels of severity. It's very easy to recognize when someone's addicted at the highest level of severity. So to recap, this slide communicates two things. One is that the more severe the dependence or the addiction, the fewer the people who are involved. That implies that as you go down to the lesser levels of severity, there are greater numbers of people with either substantial or moderate or even light substance use and substance use problems. So our services tend to become concentrated in focusing on the people with dependence. And now there's been a shift to try to identify people at lesser levels of severity. The second point about this slide is that the problems that people experience are in direct proportion to the severity of their dependence. But if you look at the width of the slide on the left side, it suggests that there are greater numbers of people with moderate substance use problems, and the number of problems that they have may add up to be equal to the number of problems that a smaller number have who have severe substance use problems. So we've got to look at the full spectrum and design our services to fit the needs of these different populations. Thank you.